Hello, good afternoon or good evening. It's a pleasure to be here. Thank you very much for the kind introduction. First of all, as it has been told, I'm based on Kuwait. I'm managing a genetic lab specialized in reproductive genetics, and I'm also co-founder of FerttyInternational IVF clinic. Today, let me see. Can you see the presentation?
Everyone can see, doctor.
Okay. Okay. Today, I want to talk about inheritable genetic disorders, the risks for the patients to transmit these diseases to the offspring, and the option they have to avoid this transmission. I will try to bring a little bit of light to the topic of genetics that I know that sometimes it looks like very tough and very complicated and difficult to understand, and I hope I can achieve that. Before talking about genetic diseases, first of all, I want to introduce the concept of a genetic variant. Genetic variants are differences in the way our genetic code, it means the DNA, it's written. And this is making each one of us a unique person, different from each other. Most of these differences in these variants are usually harmless. So I will refer them as neutral variants or polymorphic variants. But some of them can cause a disease. And we refer to these variants as mutations. I want also to introduce the concept of a gene. This genetic material is divided in thousands of subunits that are called genes. And these subunits are having instructions for a specific function of our body. So mutations that are affecting a specific gene are making this specific gene to not to work properly. So if these mutations are affecting very important genes for our body, they can disrupt the normal development and function of the body and cause a medical condition. And this is what we call a genetic disease or a genetic disorder. Sometimes these mutations are affecting genes that are so important for our development, so essential, that are not compatible with life and are causing the death of the fetus or the newborn. So in this talk, I'm going to focus in what we call single gene disorders or single gene diseases, meaning a mutation in only one gene is causing a specific disease. For example, we have a gene that is called HBB. So mutation in HBB gene is causing a specific disease called beta thalassemia disease. So how we can inherit these mutations? So there are two main ways. The mutations can be inherited from our parents, one of our parents or both of them, and we are calling these mutations like hereditary mutations, or can be new in an individual. So this mutation is not present in the parents. And what is happening is that usually the father or the mother has a mutation as new in a single sperm or egg, and this new mutation is transmitted to the child. Although this mutation is new and no other family member is having this mutation, this child from now on can transmit the mutation to future generations. So this mutation now is hereditary also. To understand how these genetic diseases can be transmitted through different generations, we have to know first that we have two copies of each gene. One copy that we inherited from our mother and the other copy from our father. So from the thousands of genes we have, from each one we have two copies, okay? And there are different ways that these genetic diseases are transmitted from father to children. And the way or the pattern these genetic diseases are transmitted will depend on the kind or the type of gene. Generally speaking, we can distinguish three types: dominant diseases, recessive diseases, and Xlinked diseases. And I'm going to explain each one in a little bit more of detail. Dominant disease. in a dominant disease, we only need that one of the copy of the gene to be mutated to be affected. Okay, as I told you, we need from each gene we have 2 copies. So with only one mutated, it's enough to be affected. This means that having a normal copy of the gene, it's not enough for this gene to work properly and to make its function properly. Usually, this person is inheriting the condition also from an affected parent. Or, as I explained before, this mutation can appear de novo or as a new mutation in this individual. Examples of these diseases can be, for example, achondroplasia or Huntington disease. As we can see here in the picture, we have an affected father that is having only one copy of the gene mutated, and the risk for the couple to have also affected children are 50%. This means that in each pregnancy, 50% of the fetus of the children has it means that in each pregnancy, the child has 50% chances of being affected as the father. Regarding recessive diseases, in these diseases, we need to have both copies of the gene mutated to be affected. This means that, that if we only have one mutated copy and the other is normal, this normal copy is enough to make the gene work properly. Usually, the individuals affected of autosomal recessive disorder, they inherit one mutation from the father and one mutation from the mother. And the father and the mother are just simply having one copy abnormal. So they are healthy, they are non-affected, and we call that they are carriers of the mutation, but non-affected of the disease. In the picture I put here, we have a couple, both of them are non-affected carriers of a recessive disorder, and the risk of having an affected child is 25%. This means that in each pregnancy, the baby has 25% chances of being affected. And examples of these diseases can be, for example, cystic fibrosis, beta thalassemia, sickle cell disease. There is a third pattern of inheritance that it's for the genes that are located in the chromosome X. And we call this type of inheritance Xlinked inheritance. The chromosome X is a sex chromosomes. Females, we all have 2 chromosome X, while men, they are only having 1 chromosome X and 1 chromosome Y. And the way these diseases are inherited are a little bit different from the other ones. So also for Xlinked diseases, we have dominant and we have recessive. In the case of dominant, only one mutated copy of a gene that is located in chromosome X is enough for a person to be affected. And this affects more or less the same to male and female. In the picture we have on the left, we see that there is an affected female, an affected mother that is having only 1 chromosome X with the mutation. So for this couple, the risk of having an affected child, independently if this child is a boy or it's a girl, it's 50%. On the other case, we have that the male is affected with an X-linked dominant disease. So the only chromosome X that this man is having is mutated. So it means that all his daughters will be affected, but because his daughters are inheriting from him the chromosome X, while all his sons will be completely normal because they will inherit the chromosome Y that is normal. One example of this kind of inheritance is Fragile X. Of course, we also have X-linked recessive diseases. And we need that both copies of the gene in each chromosome X, they should be mutated to be affected. What happened? That men only have one chromosome X. So if the only one chromosome X they have, it's mutated, this is enough for a man to be affected of the disease. Females, that we have two chromosome X, we need both copies of the gene to be mutated to be affected. So in the example I put here, we have a woman that is not a non-affected carrier because only is having one mutated copy of the gene, and the risk for the children, it's different depending if the children are boys or are girls. This couple is not going to have any affected daughter. They can be carriers, but not affected. However, 50% of their sons can be affected of the disease. An example of this kind of disease can be, for example, Duchenne muscular dystrophy or hemophilia type A. So what can we do if I know that there is a genetic disorder in my family? What should I do if I don't want to have affected children, if I want to know the risk I have to transmit this disease that is running in my family to my children? First of all, it's very important to learn about the family health history, because we need to know. Sometimes it's not easy because it will depend how big is your family. Sometimes some families are trying to hide to other members of the family that they have an affected member. However, it's very important to ask our family members if we have a name for the disease, if we have genetic reports. And sometimes we have the name of the disease because a family member affected has been diagnosed by a doctor because the clinical symptoms are matching to a specific disease. However, the mutation that is causing this disease, it has not been found or it has not been tested yet. So we have to collect all this information and provide this information to our doctor or genetic counselor. And our doctor will review all this information and request for us, if we are at risk of having the family mutation, they will request the specific test we need in order to know if we are carriers, if we are not carriers. It will be also important in case of recessive diseases that, as I told you, we need both members of the couple to be carriers of a mutation in the same gene. It's very important to test your husband or your wife also for this same gene. And when we have the family history and we have the results of our genetic test, the genetic counselor will give us our specific risk of transmitting this disease to our children. And this will depend if we are carriers or not, and if it's a dominant, a recessive, or a Xlinked disease. But what happens if I am completely healthy and there is no family history of any disease, of any genetic disease that I'm aware of? So I'm still having a risk of transmitting a genetic disorder to my offspring, to my children. Okay, so it has been estimated that everybody of us, any one of us, can carry about 5 or more mutations in recessive genes that are related, that can cause a genetic disease. So if by chance we are marrying someone that is also carrying a mutation in the same gene that we have, so we will have, we are at risk of having affected children. Some conditions, some genetic disease are more common, we know that, in certain groups of people. People that is sharing the same ethnic background, or local groups, for example, people that is living in isolated regions, or people that is living in a small island, that they are sharing, not only sharing a common ancestor, but also there is a lot of inbreeding. They are marrying with people that is living nearby them. Even they are not family, or they are not family related. Also, consanguineous couples have a higher risk of having a child with an autosomal recessive condition. We have to consider that, for example, first cousins, they share 1/8 of their genes that they inherit from a common family member. So the risk in these couples is much higher than the risk that we have in random couples. So there is any way that I can know if I'm at risk of transmitting a genetic disorder to my children? Can I be tested to see if I'm a carrier of a genetic disease? There is a test that it's called preconception carrier testing. There are several brands in the market, and this test, what it's doing is scanning usually more than 300, 400, around 400 genes that we know are causing recessive and Xlinked disorders. And we are testing all these genes in a single test. We are extracting a little bit of blood and we are doing the test. And we are trying to identify if these genes are having mutations. This test is recommended to be performed before pregnancy in both members of the couple, because then we can compare the results of both members of the couple and see if they are sharing mutations in the same gene, so they are at risk of having an affected child of a recessive disorder. This test is very important, especially if as I told you, in consanguineous couples that are very frequent in some populations, like here in the Middle East, and also in couples from that are sharing a same ethnic background. This test can help us to identify if both members of the couple are at risk. If this couple is at risk of having a child affected of a recessive or an Xlinked recessive disease. So once we know that we are at risk, that we can have a child with a genetic disorder, even we are doing a preconception genetic test, or because there is a genetic disease in my family, I can prevent that. I can stop transmitting this disease to future generation. There is one test that it's called PreImplantational genetic testing for monogenic diseases. This is one option. Obviously, there are other options, like, but it will depend on the legislation of each country, like going for egg donation or sperm donation. But not everywhere is available, and not everywhere is allowed by law. But this test, that PreImplantation genetic testing, that it's PGT, it's a diagnostic that it's made in the embryos before they are implanted in the maternal uterus, and to prevent the transmission of these genetic diseases to the offspring. So it has two main requirements. We need to know the mutation responsible for the disease in the family, in the couple. We need to know if both members of the couple or one member of the couple is having a mutation, what mutation is, and we need to do an IVF cycle. So more or less how it works. The doctor, the geneticist, has to review our case, see that we have all the reports with the genetic mutation, and they have to offer us a proper genetic counseling, explaining our risk, our chances of getting pregnant, what's going to happen, how we are going to test the embryos, and then a previous genetic test that is specific previous to starting the IVF should be done. It's specific only for the couple, and it should be done before starting the IVF, and it will help us to diagnose the embryos. And sorry. Fine. And then the couple can start the IVF cycle, and what it's done is on day 3 or on day 5 of embryo development, the embryos are in the IVF lab, in the incubator, we are removing one cell or 5 to 6 cells, depending on we are doing the biopsy on day 3 or on day 5. We are taking this sample to the genetic laboratory, and we are testing this sample for the mutation in the family. So we can know if these embryos are free of the disease or are affected of the disease. And we are only going to transfer to the woman the embryos that we know that are free from the disease. So we know that the baby won't be affected. And this is one of the ways that we have to prevent. And if we are and we are preventing in our offspring, but also we are preventing in future generations if we are avoiding to transfer carrier embryos. To finalize or to end my presentation, I think the most important thing of genetic diseases is that we need to consider that these inherited diseases are not individual diseases. Even they are affecting you, they are family diseases. So sometimes it's very important, because I face it every day, it's very important to share the information with other family members, because if you are carrier of a genetic disease, your siblings are having 50% of chances also to be affected. So it's very important that you tell them, please go and test, because if not, we are spreading the disease. And especially if you are in these cases, I explained you that in consanguineous couples or couples that are sharing a specific ethnic background. And I hope I bring a little bit of light to the topic of genetics, and I will be very happy to answer any question you might have.
Thank you, Doctor. Thank you very much. So as the format is, we have both the doctors speaking first and then followed by the Q&A. So Dr. Gautam, we are waiting for you to start your presentation. And Doctor, we would request you to stop your video share while Dr. Gautam is speaking, and please be there with us for another 20-25 minutes, after which we will be taking all the questions. Thank you. Okay. Over to you, Dr. Gautam.
Good evening, participants. Thank you, Carmen, for a very simple, lucid talk. Although this webinar was directed only for our patients from across the globe, I saw nearly 40% of the people presently are doctors. So it will be good as a counseling for them in their own rooms to counsel patients for genetic diseases as well. About 15 days ago, I had done a webinar for doctors on IUI on the same subject that we're going to lecture today. This is a more simplified lecture on intrauterine insemination. Actually, we have removed most of the bibliographic or scientific peer-reviewed references, and we're trying to tell the patients what exactly is IUI. And maybe for the doctors on board, it will be useful to counsel your patients and to provide correct guidance as well. So what is intrauterine insemination? Intrauterine insemination, or IUI, is actually one of the commonest first-line treatments for fertility management across the globe. A survey done in 2017-18 in India said that over 10 million IUIs were done only on the Indian subcontinent. So it's very, very common. So what exactly is it? IUI is the therapeutic introduction of capacitated sperms in the upper uterine cavity. Therapeutic introduction is introducing processed sperms in the upper part of the uterine cavity with the help of a silicone catheter. It's a painless OPD procedure, outpatient department procedure. So what exactly do we achieve when we do an IUI? We copy the function of the human cervix. So what are the functions of the human cervix? The human cervix gives rise to cervical secretions, acts like a physiological filter, and removes the abnormal sperms, dead sperms, vaginal epithelial cells, hair, debris, cellular debris. And the last thing it does is, if you know the steps of normal human reproduction, After these sperms are ejaculated, they find their way from the posterior vaginal fornix to the cervical crypts, where they are stored for as long as 72 hours and are thrown up in asynchronous waves towards the fallopian tube, where fertilization actually takes place. The meaning of capacitation means making these sperms imminently fertilizable. Certain chemical processes happen in the sperm head, sperm cell membrane that make them ready to fertilize the egg, which lies waiting for them in the fallopian tube. So we do carry out the cervical function in the laboratory when we process the sperm and do an intrauterine insemination. So how do we do that? We get rid of the cellular debris, abnormal sperms, seminal plasma. We pick up the good motile sperms, and using some special liquid or culture media, we do an in vitro. In vitro is outside the body. We do an in vitro capacitation. We start a chemical reaction in the sperms that makes them imminently and ready to fertilize the egg, which lies waiting for them in the fallopian tube. What are the common indications of IUI? The commonest, most used is unexplained infertility as a first-line treatment when there are, no attributable causes found from existing investigation panels. Then you have cervical dysmucoria when you don't have cervical secretions, maybe because of conization, maybe because of some cauterization done on the cervix or some cervical operation. There is no secretions that keep the sperms alive. So we bypass the cervix and put the sperms up in the uterine cavity. Male infertility is another big chunk. Oligoasthenozoospermia, low counts, low motility in the semen parameters. Retrograde ejaculation after TURP, sometimes after transurethral resection of prostate, after prostatic surgeries, you have retrograde ejaculation. So you tell the husband to have some alkaline liquid and then have the bladder full, ejaculate. When he ejaculates, the sperms land up in the bladder. Then the man maturates or passes urine, and the sperms are retrieved by the embryologist from the urine with very good results. Husband living abroad for long stretches of time. In the Asian subcontinent, you have a large percentage of men working abroad. When they come back, we freeze their semen, we process the semen, get them ready for IUI and freeze them so treatment can be done or IUI can be done even in their absence. Immunological infertility, mild endometriosis, very rare disorders like allergy to seminal plasma have also been documented. Multiple failed IVFs. We all have patients who have undergone 3, 4, 5 IVFs for unexplained infertility, and then they get pregnant after giving up, go back to doing IUI and then get pregnant. Inability to afford IVF in a lot of developing economies simply because we cannot afford IVF ICSI. The patients have to be pushed through multiple cycles of IUI, and that is another indication. What are the contraindications? Unhealthy tubes, acute genital infection, either vaginal, cervical, whatever, is absolute contraindication. Hyperstimulated ovaries and medical, psychological, social are relative contraindications. Sample collection. This is also very important to understand. The husband collects the sample by masturbation. An ideal sample to collect is a split ejaculate. That means you send the wife in with the husband for collection in a proper bedroom or collection suite, and with 2 jars labeled 1 and 2. As the man ejaculates, the first part of the ejaculate, the first couple of spurts contain all the sperms. The subsequent spurts contain only the glandular secretions, and it's easy from the split ejaculate labeled 1 with less of seminal plasma that goes into that for the embryologist to separate the sperms, more so today when we are going to do microfluidic methods of sperm retrieval in the lab. I will come to that later. So it's very important to counsel the patients about this basic thing, that if you collect the ejaculate, use the split ejaculate method, where the first spurt goes into a jar and the subsequent spurts go into a second jar labeled 2. Many a times you have this viscous sample coming again and again. So you must do a comprehensive genital culture before all IUIs are planned. If there is any glandular infection or bladder infection, because males share a common urinary and genital tract, that must be treated. If the sample is sterile and still you have viscosity, it can be broken down mechanically or enzymatically in the lab by the embryologist or the technician. In developing economies where with very low counts, we cannot afford IVF ICSI, we often attempt pooled ejaculates, where beginning early in the morning with gaps of 2 to 3 hours, 2 or 3 times the husband is asked to ejaculate. We pool the ejaculate and then try to run an IUI cycle with the pooled ejaculate. This is what I was talking. Essentially, sperm processing traditionally has been by swim-up methods or density gradient separation methods, but in the 2020s, all the good labs are going over to microfluidic sperm sorting chips, which are slides where you just put in media, put in a drop of semen, like I told you, from the ejaculate, and you have, if you see in black, the motile spermatozoa find themselves across some nano channels, and the immotile spermatozoa do not make their way through these channels. And these are non-centrifugation methods. The picture on the lower right is one of the sperm sorting microfluidic chips. There are over 20 companies that make these nanotechnology microfluidic sperm sorting chips now. So today in the 2020s, the microfluid sperm sorting has consistently and significantly increased the ongoing pregnancy rates when compared with the density gradient and the swim-up cycles, which have been in existence since 1978. Also, this is a wonderful slide, so that not to confuse you, just look at the words highlighted in pink, 5 to 10 million and greater than 10 million. We talk about pregnancy rates when the post-washed total progressive motile sperm count. So when is IUI, in layman's language, when is IUI really going to give you results? You have to understand that the best results, the highest results of IUI are about 25%. And it's only when the total post-washed motile sperm count is 5 to 10 million or greater than 10 million are you going to achieve pregnancy rates which are acceptable with IUI. This is a slide that shows you that after processing, these are how capacitated sperms look like, and we use less than 0.5 ml, about 0.4 ml that is deposited up in the uterine cavity. All you need is one of these athletes to go and fertilize that egg waiting in the fallopian tube. Today, this is a recent paper from June 2019 that tells us the importance of doing proper screening of both the husband and wife before an IUI. And women inseminated with HPV, human papilloma virus positive sperm, had 4 times fewer clinical pregnancy rates compared with women who had HPV negative partners. So even if the counts are good, but if you have infection in your semen, you're going to get lower pregnancy rates. Another concept that has completely changed over from 1978 to 2020 is the timing of IUI. We were all taught as students that IUI should be done. If you're doing a single IUI in a cycle, it should be done 36 hours from HCG injection when the follicle releases the egg. But today, peer-reviewed literature results tell us that if you are going to do one IUI, then the ideal time is 40 to 42 hours after the HCG trigger. And if we are going to do 2 IUIs, then I prefer 2 IUIs. It's only when a patient cannot afford 2 IUIs that we go in for 1 IUI. If it's 2 IUIs, We do it 24 and 40 hours after the HCG trigger. And again, when you use different medicines, your doctors are going to guide you. This is more for the doctors. If you use clomiphene citrate cycles, then 18-19 millimeter is not the correct size to trigger. The HCG trigger must be given around 22-23 millimeters. It's very important for your treating physician also to keep abreast with current knowledge and when to give the trigger. Also, one should not be canceling cycles. If you know, sometimes patients come and say, my doctor canceled my cycle because my endometrium had not reached 8 millimeters. Well, 8 millimeter is not the holy grail of getting pregnant. And there are many papers which now tell us that endometrial thickness cannot predict ongoing pregnancy achievement in IUI cycles stimulated with clomiphene citrate. We have pregnancies even at 4 and 5 millimeter endometrium, as long as it differentiates, as long as you have differentiation into triple layer endometrium, you will have pregnancies. Again, look at these two papers. One scientific paper is from 1992 and one is from 2019. But really, it has only reinforced what scientists found in 1992, that 2 inseminations before and after ovulation resulted in a higher pregnancy rate when compared with a single insemination. This is a paper from Vancouver from the time I was there as a visiting fellow. It's a wonderful take-home message. Cost-benefit analysis comparing injections and IUI and IVF, and no therapy may favor a course of 4 cycles of gonadotropins and IUI as the first line of therapy. The pregnancy rate for 1 cycle of HMG and IUI is inferior to IVF, GIFT or ZIF. 2 cycles are comparable to IVF. 3 cycles are superior to IVF and comparable to GIFT, and 4 cycles are theoretically superior to all techniques. All that this means is at least do 3 cycles of IUI using gonadotropins before moving on to IUI. And what are the reasons of these high pregnancy rates when you use injectable fertility medications and then do an IUI? Well, this superovulation means producing multiple eggs, corrects subtle ovulatory disorders, and makes the ovary size large, brings the ovary in close proximity to the fimbrial end of the tube. It enhances the pickup mechanisms. Remember, the tube has to pick up the egg which lies waiting in the fallopian tube. And the processing that we do today with the microfluidic chip enhances the fertilizing capacity of sperms. And when we put in a large amount of sperms bypassing the cervix in the upper uterine cavity, it increases the chance of getting pregnant. More the number of sperms reaching the fallopian tube increases the chance of getting pregnant. When is IUI not beneficial? Well, in older women, 39, 40, please do not do IUI. They must rush into IVF. Has the best chance of success within 3 cycles, and these 3 cycles have necessarily to be done using gonadotropins or injections to achieve an acceptable pregnancy rate. Again, these papers tell us that injections are better than tablets when it comes to IUI. And again, clomiphene was introduced in 1963 in clinical practice, and still there is no superiority of letrozole over clomiphene when used for IUI. How long should you be doing IUI? We have patients sometimes come or done 18, 19, 20 times. Do not repeat IUI more than 3 times if done using gonadotropins. Please move on to IVF today. And how much of rest is needed? Well, scientific studies have been done and published recently that all that you need is 15 to 20 minutes rest after IUI. After that, more than 15 minutes rest is really not required, and the patient can be told to go home and take it easy and do a desk job, etc. The semen sample should be processed and within 60 minutes put into your uterus. So this is very important. Please do not process a sample in one part of town, take the sample to another part of town, takes 2 hours, and then do it. Within 60 minutes of processing the sample, it should be put back into your uterus. Like any other medical procedure, IUI also has its complications. On the other hand, I will tell you a couple of complications. In my early days in 1992, 93, I've seen 2 women in the same year come with more than 20 liters of pus in their peritoneal cavity. An IUI sample was prepared in a remote nursing home in a kitchen pantry using ready-to-use semen preparation kits. And an infected sample was put into the uterine cavity. The infection traveled from the fallopian tube into the peritoneal cavity. And both the women had over 20 liters of pus. One woman died and one survived after 3 months in hospital. So please do not take IUI easily. Go to a lab which has facilities that with clean air systems and benchtop incubators, they do their IUIs. Saying that, sperms are very hardy creatures, and if you have trained technicians, this is an old paper, wonderful paper, must read for gynecologists. There was a ureterorectal fistula. Every time the man ejaculated, sperm would land in the rectum. Using a glass pipette, they would get the sperm out with a bulb and glass pipette, and then do a triple sperm washing, and then got pregnancy not once, but he completed his family of 2 with IUI and sperm retrieved from the rectum. This is the last slide. What is the take-home messages for IUI success that both patients and doctors must know, at least in the back of your minds? Do not inseminate over 0.5 ml. Many a times, general gynecologists depend on pathology labs to send process samples to their rooms, and they send a vial of 1 ml. Please do not take till the last drop. Do not go more than 0.4 ml of processed sperm when you do an IUI. What sort of catheter should you use? Well, spend some money and use the softest catheter. The softer the catheter, the better the results. We have learned this from IVF, that the stiffer the catheter, it causes sublumen microscopic endometrial epithelial damage and lowers pregnancy rates drastically. The IUI procedure must be finished within 2 minutes time. So you cannot keep struggling. The longer the procedure, you're going to have lower pregnancy rates. And to circumvent this, ideally one must do an IUI on a partially full bladder with transabdominal sonography guidance. If there is any blood inside or outside the catheter after IUI, you will find it, or the patient finds it on her panties later when she goes home, the chances of pregnancy goes down. For the doctors as well as the patients, please follow our Instagram channel, where we talk about things like I have explained now, these take-home messages. So we have case reports of how patients get pregnant, what are the ideal things to do. There are free download papers for minimal stimulation, all on our Instagram channel @MMCIVF. They're all free to download.